morning or good evening. I'm in Baltimore. Greetings from the past. I'm in Baltimore this evening, and I'm happy to talk to you briefly about considerations about reproductive health for individuals living with sickle cell disease. And as time is constrained today, I chose the 10 most important things that I think people living with sickle cell disease and people taking care of people with sickle cell disease should know about sexual and reproductive health. And my only disclosure is that I'm from Brooklyn, New York. And so number 10, this is a countdown of reproductive concerns for women and men with sickle cell disease. And the first is that I think that we should celebrate that this is a problem in sickle cell disease. And it may not feel that way if you're someone who's having challenges related to sexual and reproductive health with sickle cell disease. But survival is really the precondition for discussing reproduction in individuals with sickle cell disease. And we know that these conversations need to start in pediatrics. And I think that, that's true for two reasons. It's not just that the patients are there, but it's also that we know the parents are there. And parents who have had children with sickle cell disease, we know may alter their future reproductive plans based on the presence of a chronically ill child in their family. And they may also be interested in continuing to build their families. And so education for them about reproductive inheritance of sickle cell disease may be important. The other reason these conversations need to start in pediatrics is that children's socio-emotional and physical development is affected by sickle cell disease, and eventually in adolescence, sexual and reproductive health needs need to be addressed. And we know that this is multidisciplinary care, and so this is a short list of all the people who might be involved in the care of young people with sickle cell disease and adults with sickle cell disease. And it ranges from primary care doctors to pediatric and adult specialists, particularly those in high-risk obstetrics and in endocrinology, urology, and genetics counseling. I added, mental health services here because we know that, sexual and reproductive health, when those things are affected, it can profoundly affect how people's moods and how they do. See if I can advance the slide. There it goes. So this is just a graph of survival in sickle cell disease, and for me, it reminds me that that people are living well into their reproductive years. And while we've had tremendous success in improving the survival of children with sickle cell disease in the United States, at least, we continue to confront challenges with young adults and adults with sickle cell disease in moving the needle on survival. Nevertheless, survival is well into reproductive years. Number 9, this is a countdown. Puberty onset is often delayed. So late onset of puberty is constitutional in individuals with sickle cell disease, which is to say it is not mediated by any specific hormone deficiency or derangement. It's sort of the global milieu of the individual. And many girls start to menstruate in their mid-teenage years, where we might expect them to menstruate a bit earlier. There's probably some genotype-specific variability related to this, and this is possibly affected by disease-modifying therapy. It's not well studied. But one thing that I have seen and that it's important to know is that the absence of periods in late adolescence is not well explained by sickle cell disease. And so I have heard and seen amenorrhea, meaning the lack of menstruating, waved away as a complication of sickle cell disease. And sometimes that's true in younger girls, maybe 12, 13, 14, even 15 or 16 years old. But as girls get older, if their periods don't come on, that somebody needs to look for a cause that is not sickle cell for that. Menstrual cycles are expected to be regular, and so if they are irregular or exceptionally bothersome, heavy, or painful, speaking with a gynecologist is warranted. Families and children need support as they enter middle and high school, especially as many of them are late bloomers. Many of my adult patients ask me for help gaining weight. We know that many children with sickle cell disease are skinny, and we also are learning that, especially with the advent of disease-modifying therapy and chronic transfusions, that we also have a new population of children and adults at risk for being overweight. In any case, all of these families and children need particular help as they may be late bloomers going into middle and high school, and there can be social consequences for that. The number 8 issue in my top 10 is that priapism is a truly awful complication of sickle cell disease. And I think that we need more provider-initiated screening to identify cases of priapism. We know that not all boys and men will readily volunteer this to their providers. It seems to affect about 30% of boys and men with sickle cell disease, which is a lot. And the onset tends to coincide with puberty and sometimes remits in the early 20s, but can continue. And we don't have any definitive treatment to address priapism. Some people are interested in using crizanlizumab for this. And others are using chronic transfusions. And just like anything, when it works, it's great because it works, but we don't have any definitive treatment for priapism. The psychological burden of priapism is surely underappreciated, and there are several reasons that this causes a tremendous psychological burden. First of all, it's extraordinarily painful and leads to many encounters with the healthcare system during severe pain episodes. And so we know that that can always present challenges for individuals with sickle cell disease trying to seek appropriate treatment for pain. But of course, this involves a particularly sensitive part of the body. And I think that we need to recognize that young men in particular are especially vulnerable when they have this complication, and they need a urologist if they're being seen in urgent or emergent care. Another aspect of the psychological burden of priapism is that it's extraordinarily disruptive of sleep. So it's really common. It's normal to have erections when you sleep, and it's really common to wake up at 2, 3, 4 in the morning with priapism that won't go away. And many men who learn to cope with this go for long walks in the middle of the night, take showers in the middle of the night, or have to go to the emergency room in the middle of the night. And it turns out that there can be sort of no end to sleepless nights with this. And we know that mood and sleep are very closely intertwined. And so I think that there's probably some of the burden is just contributed around priapism due to this incredible burden around nighttime pain. And finally, we know that persistent priapism can lead to impotence, and that has its own set of consequences. And so it is our practice to involve urology promptly and to try a disease-modifying therapy, hydroxyurea, crizanlizumab, chronic transfusions, to see what we can do. And just to not to put too fine a point on it, but priapism is such a bad complication of sickle cell disease that it's an inclusion criteria for many transplant trials. I think that's a reflection of the fact that we lack good therapies, and also it's just a dreadful complication of this disease. This was taken from a clinical trial that's being conducted in the United States that you can find on clinicaltrials.gov, but just to highlight that recurrent priapism is considered severe enough to be criteria for experimental transplant protocols. Number 7, we'll now go through a series for women. Number 7 is that periods can cause sickle pain. So this isn't just pain. This isn't just painful periods, but it's actually sickle pain with periods. And my colleague Diva Sharma did a beautiful study where she talked to women with sickle cell disease about this pain, and she identified that some women with sickle cell disease only get period pain, which is called dysmenorrhea, while others get vaso-occlusive pain or sickle pain, and some identify having both. And I think this both, I always find this fascinating as someone without sickle cell disease, because I think it speaks both to the unique pain experiences that are different between getting menstrual cramps and getting sickle pain, and also the nuances that our patients are able to share with us and teach us about with respect to their pain. We don't know whether menstrual suppression is a good way to treat menstruation-associated sickle pain, but it's reasonable to suppose that if you're not cycling and getting your period, that this might be one way to address some of those severe painful episodes. Number 6 on my list, contraception. It's complicated. So women with sickle cell disease around the world report high rates of unplanned pregnancy. And this comes from studies I've cited at the bottom from England, Brazil, Jamaica, and the United States at least, and I'm sure Australia and perhaps other countries can add knowledge to this field soon. But we know that there's a high rate of unplanned pregnancy and low use of highly reliable forms of contraception, and that's a trend that seems to be stable over some number of years. And so there's really an opportunity to improve at least education and conversations around this to inform decision-making. It doesn't mean that we force our choices on other people, but only to provide education to help people make choices. The next aspect of contraception that's difficult is that sickle cell disease is a high-risk thrombophilic state, which means it's an increased risk for blood clots. And we don't know whether the risk of blood clot with estrogen-containing contraception is unacceptably high in individuals with sickle cell disease, but in other blood clot causing conditions with an equal risk of blood clot as sickle cell disease, estrogen containing contraception is thought to be an unacceptable form of contraception. And it's our practice at Johns Hopkins not to use estrogen containing contraception except where the risks of pregnancy are so high that they are thought to outweigh the risks associated with estrogen containing contraception. And we sometimes forget it's not just sickle cell for our patients, but that sickle cell is associated with all kinds of other complications that should further add nuance to how we counsel patients about contraceptive choices. And strokes, migraine headaches, and renal disease, kidney disease may be further complications that should make us pause before we prescribe estrogen containing contraception to our patients. This is some data from Baltimore. We asked women at Johns Hopkins about their preferences with respect to contraception, and they shared with us some of their most important priorities for birth control. This can be a kind of busy graph to look at. On the y-axis is percent of respondents. There were a bit over 70 individuals who participated in this study. I encourage you to just fix your eye on the tall black bars, which are the respondents who answered that something was very important. And so you can see that many of these things, preventing pregnancy, HIV, the effects on sickle cell disease, were very important. But I think this is interesting because taken together, many of these things point to the potential appeal for things like long-acting reversible contraception, like IUD and implants for women with sickle cell disease. And that's because those forms of contraception are outstanding at preventing pregnancy, are associated with menstrual suppression, which may improve sickle cell symptoms, require no daily action. And I really appreciate our patients have a tremendous pill burden every day. And so reproductive options, contraceptive options that don't need any memory of pill taking, I think could be attractive. And finally, some of the issues around partner discussion may be obviated with these forms of contraception. Number 5, everyone deserves preconception counseling. So we tend to focus on women when we talk about preconception counseling, but there really are a number of aspects of preconception counseling that affect everybody with sickle cell disease. And this includes the need for hemoglobinopathy testing for partners to assess risk for conceiving a child with sickle cell disease. It includes genetic counseling provided for patients at their education level and with enough talk back to affirm that the patient understands what they're being taught. It may include referral to artificial reproductive technology specialists, that's the reproductive endocrinologist, for consultation. It requires a discussion about which medications to stop and start when one tries to conceive. Generally, hydroxyurea is stopped in this setting, and decisions about whether or not to initiate chronic transfusions should be made in discussion between the patient and doctor. And of course, we have very little data about what it's like to be a parent with sickle cell disease. And so we have very little to offer, but I think, the internet and peer support groups offer a tremendous opportunity for individuals with sickle cell disease who are parents and who are thinking about becoming parents to find one another and think about this together. On the other side, I've just put a few details about care of women pursuing pregnancy. And I usually think about this with my patients, if I can, before they become pregnant. So talk about the need for high-risk obstetrics and the need for assessing end organ function, and to think about pain planning, and also to talk a little bit how their hips are doing. So women with avascular necrosis in their hips may have a hard time delivering a baby by vaginal delivery. Others do just fine. So number 4, pregnancy is a high-risk condition, and it requires multidisciplinary care. So we know that women are at increased risk of complications and in some settings, even death. New data is emerging that suggests that the mortality risk, so that's the risk of death, may be significantly modified with appropriate multidisciplinary care, incorporating expertise from hematologists and high-risk obstetric care. There's some interesting new data from Canada about predicting who is at risk of complications with greater precision. And it's interesting because it could inform our transfusion strategies and other ways to think about what kind of monitoring and care women with sickle cell disease need during pregnancy. The other thing is that we have this unacceptable habit of talking about sickle cell disease as milder and more severe phenotypes. And in pregnancy, those distinctions tend to get blurred. So women with compound heterozygous forms of sickle cell disease, which is what we tend to mean when we say less severe, and really we should say compound heterozygous forms of sickle cell disease. Women with those forms of sickle cell disease seem to be at increased risk for pregnancy complications, just like women with sickle cell anemia, SS, and beta null thalassemia. There are fetal risks in pregnancy, and then of course there's a risk of miscarriage, stillbirth, and small for gestational age babies. I just love this slide. So there are many changes to the body of women with sickle cell disease as they become pregnant, and these risks become more significant across the pregnancy. And I like this picture because I think what it highlights is that when you're in your third trimester and that baby is pushing up on your rib cage and pushing on your lungs, it's easy to imagine that both is a time associated with more pain and more risk for acute chest syndrome. And indeed, that's what we see, that the third trimester is a particularly perilous time for women with sickle cell disease when they're pregnant. And number 3, fertility preservation exists. So this beautiful, colorful panel going down the right side of my slide is actually staining for ovarian follicles. Those are baby eggs from girls with sickle cell disease who underwent ovarian tissue cryopreservation before a bone marrow transplant in Denmark. And I just think they're so pretty to look at. I just wanted to show you what eggs look like. In the United States context, fertility preserving methods that are standards of care include sperm banking, egg freezing, embryo freezing, and ovarian tissue cryopreservation. Ovarian tissue cryopreservation is appropriate for premenarchal girls, whereas egg and embryo freezing is appropriate for postmenarchal girls and women. As of now, the one group of people for whom fertility preservation remains experimental is prepubescent boys for whom testicular tissue cryopreservation is not yet a standard of care. And this is most commonly used in bone marrow transplant, but my research and that of colleagues in England and in other places suggests that there may be other indications for fertility preservation, if not now, in the near future. And I wanted to show you a little bit about what sperm and egg counts look like in individuals with sickle cell disease. So these come from 2 studies. On the left is 2 bar graphs that compare sperm counts and concentrations in individuals with sickle cell anemia, so SS and S beta null thalassemia, to people without sickle cell disease and presumably without any other disease either, so healthy controls. And you can see that individuals with sickle cell anemia have much lower sperm counts at baseline than individuals who are unaffected. And I think this is really important because as a community, we've started having a growing number of conversations about the effect of hydroxyurea on fertility. And it's important, especially for young men and men who are thinking about reproducing who've been taking hydroxyurea, it's important for them to know that even before the hydroxyurea, there are risks to sperm in sickle cell anemia. And so on the right, pretty clearly demonstrates a hydroxyurea effect on sperm. You see the left bar says M0, that's month 0. This is sperm counts in a group of men before they were treated with hydroxyurea, and M6 shows their sperm counts after 6 months of hydroxyurea treatment. Now, this is perhaps distressing at baseline, but in fact, it appears to be to some extent reversible. And so this is why I show these 2 things together, because I think that we need to hold in one hand the idea that sickle cell anemia has negative effects on sperm, even as we think about the effects of hydroxyurea, which again, in boys appear to be reversible, and there seems to be some reversibility of that effect in men, but studies are ongoing. And so this really speaks to the fact that if you are a young man or a boy or a parent of a boy or a young man with sickle cell disease, this really needs to be part of an ongoing conversation if you are concerned about sperm counts for your child or for yourself. Ovarian reserve in women with sickle cell anemia is my area of study and interest, and This is perhaps more complicated than sperm in some ways. With sperm, we can sort of see them and you either have them or you don't. With eggs, they're a little harder to see and a little harder to measure. The measures give us a sense of the quantitative amount of eggs that people have, but they don't give us a qualitative measure that's like the quality of the eggs. And we know that for all women, no matter whether they have sickle cell disease or not, as you age, the quality of your eggs is less good. Among the many insults of growing old. What this graph shows is anti-Mullerian hormone, which is a measure of egg supply in about 90 women with SS disease. And let me just walk you through what you're looking at here. So on the x-axis, you're seeing age groups, samples grouped by age. So it starts with 20 to 25-year-olds and culminates in 46 to 54-year-olds. And the bars are the distribution of anti-Mullerian hormone in women with sickle cell disease, with the middle, the sort of dark gray bar being the median value. This dashed line is our clinic's cutoff for diminished ovarian reserve. Diminished ovarian reserve occurs normally in women over age 35 or so, and is a risk factor for infertility. But it is best defined as a predictor of treatment for in vitro fertilization in women who already have a diagnosis of infertility. Nevertheless, it's a recognized risk for miscarriage and infertility. And what I hope you're seeing is that women with sickle cell anemia starting in their 20s and certainly into their 30s have diminished ovarian reserve. The other thing that this graph shows, so these dark black lines are median anti-Mullerian hormone values for age-matched controls. And so you can also see that at every age group until women are in their 40s, really, there's a meaningful difference between the anti-Mullerian hormone levels, the ovarian reserve of women with sickle cell anemia compared to healthy women. And so number two is that artificial reproductive technology can prevent sickle cell disease. It can also be used in the setting of fertility preservation to become pregnant. Until recently, we've had an extraordinary paucity of data on this subject, but a recent report from our colleagues in London gives us some details about 60 couples with sickle cell trait or disease who are at risk for having a child with sickle cell disease and who elected to use pre-implantation genetic testing and in vitro fertilization. And this was made possible because the National Health System in England covers 3 cycles of IVF with PGT for all couples at risk for many different diseases, including sickle cell disease and CF among them. And in this cohort, they report pregnancies in 3 women with sickle cell disease who were 31 to 35 years of age, who were pursuing IVF with pre-implantation genetic testing, and they all conceived, and had babies. The live birth rate in the whole cohort, meaning among all 60 couples, was 63%. The authors speculate that it might have been higher, but some patients dropped out. And I include this point because whatever the reason is that one is using in vitro fertilization technologies, it's a very stressful thing to go through. And the psychological burden on couples can be very intense. And we know from the infertility literature that interventions to provide psychological support for families going through this can decrease their rate of dropout, which can increase their chances of success and having a pregnancy through this technology. We know that information about IVF with pre-implantation genetic testing is interesting to parents of children with sickle cell disease and young adults with sickle cell disease. We also know that most of the literature is written at a level that is inaccessible, at least to the average American. And my group has been involved in trying to change that, and we hope to be able to share work with you soon to provide higher quality education about these topics to our patients at an appropriate reading level. And I have to stress that this is a reproductive choice. So this isn't, and this is certainly not a reproductive obligation. It will never work if it is a coercive situation. And local insurance coverage is part of what informs this choice. But for some people, this just isn't the right way to build their family. We hope to be able to show you by this time next year that offering IVF with pre-implantation genetic testing is a cost-effective approach for preventing sickle cell disease. And my last pearl is to aim high and individualize reproductive health care for individuals with sickle cell disease. We know that this care is complex, but it's very necessary. We know that there's little data, and I didn't even begin to talk about pain with sex and excitement, which is common. And that's partially because we just don't have that much data on this subject, and also because we have an amazing patient panel, and I'm sure they can teach us more about this than I ever could. And, you know, I think the other thing to the clinicians out there is that we know individuals with sickle cell disease receive frankly incorrect information about fertility and reproduction. And it really speaks to the need of high quality specialty care. And it also speaks to the need for providers to take the initiative to address these issues, because people in the emergency department, people in other areas of medicine who lack expertise seem willing to opine in ways that do our patients real disservices, because it makes them think that things are not possible when in fact they may be, among other problems. And so in conclusion, due to the lack of data and due to the existence of data, doctors and patients must partner for shared decision-making in this context, cultivating honest conversations and sharing a vision and an understanding about what patients' hopes and dreams are, so that we can do what we do in medicine, which is to help make sure people live the lives that they want to live to the greatest degree possible, given the hand that they have been dealt. And with that, I will show you, this is a reproductive life plan. The NHLBI thinks everybody, whether they have sickle cell or not, should have a reproductive life plan. And so this is an example of a conversation you can start having with your spouse, or you can start having with your patients, or you can start having with your adolescent, to help think about when various aspects of reproductive life may be relevant for you or your family members. I'd like to say so much thanks to the Australian Sickle Cell Advocacy, Inc., and congratulations on this exciting conference. Thanks to my friends and colleagues at the Sickle Cell Reproductive Health Education Directive, and my friends here in Baltimore, and my funders. And I'm happy to take questions, and come visit us in Baltimore. Thanks.
That was a great talk, Dr. Perker. It's a lot to unpack. So we have a couple of questions in the chat, and I think I have some questions that we all would benefit from hearing your perspective on. So you and I have talked a lot about kind of the burden that pregnant women in this community face because of lack of treatment options. So one of the questions that came up in the chat was, how soon, like if you're planning on conceiving, when do you have to come off of hydroxyurea?
So that is a really important question that we don't know the answer to. And so let me tell you a little bit about why we don't know the answer to that question. The first reason we don't know why is that it hasn't been rigorously studied. It's a difficult question to rigorously study. In the absence of rigor, and there hasn't been much incentive to study it, is the other problem. But in the absence of rigorous study, we know anecdotally that women get pregnant on hydroxyurea. And it's important to remember, right, pregnancy is complicated. Getting pregnant is complicated in as much as, yes, you may be on a drug that maybe or maybe not has fertility effects, but also you have to feel well enough to have sex. And so if you're feeling better because you're taking hydroxyurea, maybe you're going to have more sex. So that might be a better way to get pregnant, right? But the reason that we think that you should stop hydroxyurea is because there's a risk for teratogenicity. That means that it could cause harm to the fetus. And so the practice is to stop hydroxyurea when women say that they want to get pregnant, usually. But that can be really difficult for patients who don't have access to transfusions and have very severe disease. But the rationale for that is that it is a teratogenic, which means that it could be harmful to the fetus.
Okay, so that was the follow-up question. So what are the options for a woman who's trying to get pregnant, go through a pregnancy, who is on hydroxyurea? Like, that's really scary to have to stop your hydroxyurea. So what would you recommend?
So this is a conversation. I can't make a general recommendation. So the reason that the number one point about reproductive health is that you have to have a partnership with your expert physician is because these decisions have to be made on an individual basis. So the only other treatment that is used for women with sickle cell disease when they are pregnant are chronic blood transfusions. And those decisions are made based on disease severity, disease type, of the ability to receive blood transfusions and sometimes logistical options. Not everybody agrees that women with sickle cell anemia should be put on chronic transfusions empirically. Some people think that you should take a wait and see approach to chronic transfusions. But if you look around at what's happened during the COVID pandemic with seeing whether we can put the vaccine in pregnant women, that provides a good perhaps way to think about what the challenges are in sickle cell disease, which is that it's the FDA makes it difficult for us to give drugs experimentally to women with any disease who are pregnant. And so we are going to have to figure out how to overcome some of those barriers to figure this out, because certainly it would be attractive to understand whether we could safely give crizanlizumab or voxelotor in this setting. Unfortunately, we just don't know the answer to that yet.
Okay, another question that I see is for an SCD warrior undergoing PGT, what are the additional risks?
Oh, what a great question. So the first thing I think about when I think about this is the stim. So to undergo in vitro fertilization, to have an egg harvest, this is for fertility preservation, or in vitro fertilization, it's the egg harvest. And the egg harvest involves stimulating your ovaries to make a lot of eggs. So one thing that does is it increases the amount of estrogen in your body. When we increase the amount of estrogen in your body, you're at increased risk for a blood clot. So some centers choose to put all women with sickle cell disease who are having their ovaries stimmed on anticoagulation. Another risk is that you can have pain crises and acute chest. These are reported anecdotally in the literature associated with this. And then it requires anesthesia to harvest eggs. And so we know that there are risks to receiving anesthesia as an individual with sickle cell disease. Our anesthesiologists in the US tend to give dexamethasone, usually as a nausea medicine after this procedure. And we also know that steroids are risky for individuals with sickle cell disease. Although the risks of egg harvest have become lower and lower over time, there are still risks associated with this. And it's called ovarian hyperstimulation syndrome. And so when my patients go through egg harvest, I always recommend that they weigh themselves every day. This is not an evidence-based recommendation, but one of the first signs of ovarian hyperstimulation is that you start retaining fluid. And so I always think that if I saw their weight going up, that might make me worry that they were having some of these complications. And we wrote a brief report about this. It's about as much as is published on the subject that at least talks through the theoretical risks for individuals with sickle cell disease going through an egg harvest.
Okay, so another thing that you and I have discussed is like high risk OBs, and how I told you that as an advocate, I hear friends who get turned away, or they see an obstetrician who they feel like really isn't prepared. So one of the questions is there somewhere that they can go to educate themselves on how to take care of women with sickle cell?
The OBs can go? Well, that's a really interesting question. So there, the Maternal Fetal Medicine Society is charged with training people to take care of individuals with high-risk pregnancies, including sickle cell disease. I do some lecturing there. And so in the US context, at least, I think finding a center, usually it will be an academic center where there's large populations of sickle cell disease patients. That's a good way to find some MFMs, some high-risk obstetricians who have expertise. And if you can't be seen regularly in that setting, you might at least be able to go for a consultative visit so that doctor could provide recommendations for your regular OB care.
Okay, so let's take a step back for a second. I want you to share with this audience from a provider perspective what you think the benefit of pre-contraception counseling is and genetic counseling.
Pre-conception counseling or pre-contraceptive?
Pre-conception.
Pre-conception, okay. So, I think I always say that if you don't plan, you take away some of your choices. So with preconception counseling, I think it's an opportunity to address misconceptions. It's an opportunity to talk about worry, and it's also an opportunity to plan together and think and anticipate some of the challenges. So to think about how you're going to manage pain, to think about whether or not a patient is suitable for chronic transfusions in this setting, to think about what medications need to be stopped. So chelators, right, are a prime suspect in this, as are NSAIDs. These are drugs we don't take when we're pregnant. So thinking about those drugs, preparing for the initiation of aspirin to reduce the risk of preeclampsia. I start all women who tell me that they are going to, who they're pursuing pregnancy on a prenatal vitamin, just to make sure they've got one. So, I think that's part of it. The other part is helping patients receive hemoglobinopathy testing for partners. I've been really impressed over the last number of years by how many people think they know whether they carry a sickle cell trait who don't know. And we've not only diagnosed sickle cell S trait, we've diagnosed C trait in a partner, and we've even diagnosed sickle cell disease in a partner in the last 3 years. So I think reducing the barriers for partner testing for trait is really important. And the other reason that we need to take responsibility for that, at least in the US context, is that many people order the wrong test or don't know how to interpret the test. So I tend to take some ownership over that.
That makes sense. Another question just came up, and one of the things that I've learned from you and Dr. Kim Smith-Whitley is that your hormone levels can kind of play a role in your sickle cell. So somebody wants to know how menopause can affect sickle cell.
So the most true answer to that question is we don't know, because it is not studied. I think there are two caveats to that. There is some suggestion that women have less pain after they achieve menopause, and it may be that that's due to a diminishing hormonal cycling. The other thing that sometimes comes up is that some women, when they have menopause, are candidates for hormone replacement therapy. It used to be more universal, and now it's more narrowly considered. The type of estrogen that's used to replace estrogen in women who are menopausal is not the same as the estrogen that is used in contraception. And so universally preventing access to that form of estrogen is probably not warranted. And this also comes up in the less common than menopause setting of caring for women who are transgender. So transgender women with sickle cell disease who wish to have estrogen therapy. The estrogen that is used in that context, again, is not the same kind of estrogen that is used in contraceptive pills. And so we have fewer barriers to those treatments for our patients.
Okay. Another thing that comes up a lot from both providers, families, and warriors is that, when they go into their appointments, they're talking about pain, they're talking about organ damage, and they just don't feel that that appointment gives them enough time to bring up reproductive health. So what is your advice to families and to warriors? Like, how do we implement reproductive health into these conversations?
Whew, that's $1 million question. So I think to me, and I say this, Tiana, that everybody should come to their appointments with an agenda. And I teach my young adults that when they come to their appointments, I expect them to have an agenda, right? In work, we don't have meetings without agendas. When I walk into a room as a physician, I have an agenda. I encourage patients when they walk into a room to have an agenda. And so if some aspect of your reproductive health care is high on your agenda, then you need to share that with your physician. And if you have not gotten the answers that you feel that you need to figure out how to have a conversation with your doctor about either, one of the challenges here, Tiana, of course, is that there's not really universal agreement about who has these conversations, right? So we know that individuals with sickle cell disease tend to like to hear from their hematologists, right? Because we have close relationships with our patients and we're experts in sickle cell, and sickle cell touches everything. But the truth is that GYNs and high-risk obstetricians play a very significant role in this counseling. And so it may be that for some of these questions, the right answer is, that's a great question. Why don't you meet with the genetics counselor to talk about that? Or that's a great question. Why don't you meet with a high-risk obstetrician so you can talk more about what it's like to be a pregnant person with sickle cell disease? Once you've done some of those things, you can come back to your hematologist and say, I'm ready to have a conversation about how we're going to treat my sickle cell disease while I'm pregnant, or I'm ready to have a conversation about what kind of birth control you recommend for people with sickle cell, because now I understand all the options that are out there. Does that make sense?
Perfect sense, and that's really great advice. Another question is coming in about menses and cycles. And so would you say in your practice and in your experience, have you seen that a lot of young girls do have an increase in crisis when they are on their cycles?
Yeah, so this is a great question, and my colleague Diva Sharma has published a bit on this. It does look like in some of her sort of squinting at some of the data on pain crises, particularly from the cooperative study of sickle cell disease, that women of menarchal age, so adolescent to adult women, did have more hospitalizations for pain in the cooperative study than men. Of course, this is likely to be a multifactorial finding, but it does suggest that pain associated with menstruation could be a driver of hospitalization. And I certainly think, again, even in the absence of population-based studies that give us the answer to that question, the answer for an individual may be, every time I get my period, I end up in the hospital. And so for those patients, talking about long-acting contraception that can suppress periods and that does not cause infertility may be a really good choice.
Okay, and our organizer, the woman of the hour, she has a question. So Agnes, go ahead.
Thank you so much, Dr. Perker and Tiona, for joining us. And this is a very, very important topic. We seem not to have a lot of studies and a lot of talk about reproductive, and obviously this was a deliberate move to highlight this topic, and the organization that Tiona and yourselves and I'm part of as well, that we should, let me put my hand up, that we should highlight the importance of discussing reproductive health in sickle cell warriors. So well done on the organization, because you are the founders, and I can't just wait to see what you'll be doing this time next year. Oh,
thank you for the plug, Agnes. Thank you for the plug. I was going to do it at the end, but we'll take it.
So yes. The question, I have a question. You spoke about alternative ways of getting pregnant for sickle cell warriors. I just wanted to find out, in terms of, because they're under a lot of hormonal therapy, I presume, if they're having like IVF and them, does that affect the sickle cell warriors and their interaction with other medications, and just what does the hormones do to the body for the sickle cell warrior?
That's a really important question. So, if I think the hormones you're talking about are the ones that stimulate the ovaries to make eggs before the egg harvest. So the good thing about that experience is that it is brief. So it's not an experience like taking birth control where you take it, right? You have to continuously be exposed to it. It's really over a cycle. So it's over a couple of weeks that you're exposed to these medications. My practice for women who have severe forms of sickle cell with, SS disease and S beta null thalassemia, is to exchange transfuse patients before they start these cycles. And I have no data that supports that practice. It's important that people know, when I'm just using my expert opinion versus when I have data. I very much hope I'll have data someday, but my rationale for that I can share with you, which is that this is a very expensive and invasive experience to have. And if you have a pain crisis or get an acute chest in the middle of this, gosh, I don't want to have to stop your egg harvest because you're having a sickle cell complication. And I think that that's less common, but I want to do everything I can to make sure it doesn't happen for you when you're going through using very expensive medications and a very invasive experience. I want to make sure you don't have complications from your disease, and exchange transfusion is easily the best way that I can do that in this setting. Make sure you're feeling as well as possible. So that's what I do to protect patients when they go through this. For patients who have a history of blood clots, we talk about what kind of anticoagulation might be appropriate in this setting. And in general, I try to stay in close contact with the reproductive endocrinologists who are providing this care, because of course, reproductive endocrinologists are not sickle cell specialists. And so we have to help them understand the ways in which our patients are uniquely fragile and have unique needs. Another Pandora's box in all of this is whether or not you should stop taking your hydroxyurea before an egg harvest. And there is truly no data about this. And I think it's a really vexing question. And the reason I think it's vexing is we know hydroxyurea is profoundly protective against sickle cell complications. But the practice in women with cancer who are getting their eggs harvested is to try to make sure they haven't been exposed to chemotherapy for 3 months before their eggs are harvested. So this is a really tough decision. And so when possible, I will stop hydroxyurea. Will I stop voxelotor or crizanlizumab? I don't know. Probably not, but is that based on anything? No. I mean, it's based on thinking about mechanisms, but it's not based on any data that I have. But I think these are some of the other questions that at least whoever's making the decisions with the patient needs to think through, even though there's not a right answer, right? For some patients, it may just be the risks of coming off hydroxyurea are just intolerable. For others, it may be feasible to consider it.
Mm-hmm.
I guess there's a lot of study that needs to happen in terms of reproductive health and sickle cell warriors. I have another question that I'm passionate about, and I've talked about this before. How about the people living with the sickle cell trait, like sickle cell trait warriors, as we call ourselves? I've told you this before, that I'm one of those who almost died during pregnancy because I believe there's no data. And one day, I think I'll go and retrieve my records to see what happened to my body during the period. What do you think happens to people with sickle cell trait? Are they affected in a similar way or anything like that?
No. So there are limited studies, but we do not think that sickle cell trait is a risk for adverse outcomes in the same way that sickle cell disease is.
Okay. Well, I have another thing that I want us to go over. Huh?
No, there's more questions in the chat box, Tiona. You can go ahead.
Yes, I saw them. That was actually one of the questions that you asked, Agnes. Somebody wanted to know if there were any studies specifically on trait and reproductive health. And one of the things that I'm not sure if everyone knows is that Dr. Perker, she is like a research nerd. So give her some time and she'll have covered all of this. I wanted to know well, I think that this would be helpful because you know that the first time I read one of your articles on hydroxyurea and ovarian reserve, I wanted to throw it in the trash. So a question that I wanted you to address for the community is, what do you say to the parents of a young boy who are worried about the effect on sperm count? And what do you say now to like the parents of young girls who are worried about the potential implications of hydroxyurea and ovarian reserve? What's your advice?
Yeah. So Tiana, one of the great things about my new life in adult sickle cell disease is that I am spared this very difficult thing, which is counseling parents of children with sickle cell disease. And I say that with great compassion, both for parents and also for my pediatric colleagues. I think that we need more evidence. And I think also that frank conversations about what we do and do not know about fertility and hydroxyurea need to be accompanied by frank conversations about how sickle cell disease can affect your life. And so, we have good data that shows that pediatric doctors, and I'm not pointing fingers here, I'm just saying as a population, we pediatrically trained people tend to avoid some of the really difficult aspects of sickle cell disease, partially because many of those things occur in adult care. But I think that the time has come for us to really start engaging families in the truth about how difficult this disease is for young adults and adults. And the reason that I think that is because to engage meaningfully about the theoretical risks and even perhaps real risks to fertility with hydroxyurea requires also engaging with the real risks, and these are not theorized, about living with sickle cell disease that is untreated. And so I think that I think that we should not be talking about hydroxyurea as if it is fighting against fertility, because we have fertility preserving tools. So we should be talking about hydroxyurea and fertility, not hydroxyurea or fertility. Just like in the cancer world, we don't talk about treat your cancer or preserve your fertility. We talk about treat your cancer and preserve your fertility. So I think that paradigm is really important in sickle cell disease. And I think the other thing that really needs to happen is a very painful, it's not easy to talk about how difficult life as an adult with sickle cell disease can be. It doesn't have to be, but can be. But I think that's part of hydroxyurea counseling as well. And so I think those things have to go together.
Right, that makes sense. Are there any additional prenatal vitamins that women with sickle cell should be on?
No, the only thing that I think about, so there's really different ideas about whether women with sickle cell need more folic acid than normal pregnant women who need more folic acid. So in the UK, they tend to put women on 4 or 5 milligrams of folic acid. In the States, practice sort of varies. There's no data. Everybody needs a little more folic acid in pregnancy. Whether you need loads more as a person with sickle cell is not clear. The one thing that I always look for in prenatal vitamins is the amount of iron in them. So if you're an overloaded individual with sickle cell disease, you don't need any more iron in your prenatal vitamin. And the iron in prenatal vitamins causes side effects like constipation and stomach pain. So I try to help people find prenatal vitamins that are not enriched with iron if they have iron overload.
Okay, well, that was a perfect segue, because the follow-up to that question, somebody wanted to know, were there any contradictions or interactions of their sickle cell treatment that they would be on, or that would interact with their prenatal care?
Oh yes, all kinds of medications. That's why we have to talk. Right, so chelators, the medicines that reduce iron, need to be stopped. Ibuprofen, naproxen, I don't know, there's so many, hydroxyurea. I mean, it's really ACE inhibitors. It's a tremendous number of medications that we do not continue in pregnancy. And so it really needs to be addressed. You really need individualized care for this.
Right. So that's why we were pushing like shared decision making and the merger between, practices. So Agnes, you have another question?
Thank you. I'm loving the discussion. Thank you so much again, Dr. Perker and Tiona. My question is technical, like in terms of managing pregnancy, what advice would you give for sickle cell warriors, like a strict regime to follow, for example, up to what period, up to what weeks should they if they are in employment, for example, depending on the kind of work they are doing, what sort of plan should they have when they should rest? Do they have like to have a strict regime to rest for maybe the last 3 trimesters to actually be able to just relax and not try to, to try avoid all these other complications? Is there like a plan to give to sickle cell warriors, women?
No, but if you want to help us make one, that would be great. I think the challenge, that's a very sincere thing. I think the challenge again is that everybody's a little different, and how pregnancy affects every individuals is a little different. The kind of work you do, right? If you do kind of work where you're up on your feet a lot, or you work at night, or you're accustomed to getting not that much sleep. One thing I always talk about with my patients is that pregnancy is a stress on the body, right? And so we know that stress in many individuals with sickle cell disease precipitates pain. So really thinking about the sources of stress in your life, anticipating that being pregnant and having a newborn are novel sources of stress, right? And thinking about how you plan and your family plans to manage those kinds of things is always great when it's possible.
Well, Agnes, you're on our advisory committee, so that can be your first project.
Could be one. That could be one. You know, because I was just looking at, I think somebody posted like a pen diary, a pen chart or something like, would you think of something just like a plan to know that, you know, at 36 weeks or whatever months I should be considering this, at this period I should be considering just to protect yourself and your unborn child. So
yeah, I mean, I think that there's just not a right answer. You know, there are really culturally different practices in this way as well. You know, in the United States, we're probably about as hard on pregnant women as anywhere in the developed world, or the resource intensive world, which is to say we let pregnant women work a long time and a lot of hours, and we put them back to work very quickly. So there's very poor maternity leave, right, in this country. So I think some of this is about what cultural expectations are for pregnant women with sickle cell disease. But again, I think the other piece is about what your body can do. You know, women who have avascular necrosis of their hips, I always worry about hips in pregnancy, not just at delivery, but we know, right, that the ligaments in your hips get loose when you're pregnant, so that your pelvis can stretch out so you can deliver the baby and carry the baby, but that may be associated with pain. So really thinking through, you know, if you have a job where you're on your feet all day, is your back going to hurt, or your hips going to hurt? What's your plan for that?
There are two last questions. Someone wants to know, what are the impacts of iron overload during pregnancy?
That's a great question. We have not identified any particularly increased risk associated with iron overload in pregnancy, except I will say that we know that if you're severely iron overloaded, that's a risk factor for having bad outcomes if you have organ injury. So if you get sick during pregnancy and you are severely iron overloaded, you might be more worried about that individual than someone without iron overload. So that's probably the context in which I would be most worried.
Mm-hmm. And I know we've discussed that there are some women in the last trimester of pregnancy who maybe take hydroxyurea. Someone said that they're aware of people who stay on hydroxyurea for their duration, like the whole pregnancy, and they wanted to know if you've had any experience with that.
I have not had any experience with that. It is not our practice to continue hydroxyurea in women who are pregnant. However, there are people who are, at least in the US, who are particularly interested in this question in the third trimester. So you might think if you're playing a thinking person's hydroxyurea game, and you're thinking about risks of malformation, which is one of the that's what we mean when we say teratogenicity, that the fetus is fully formed in the third trimester. And so the risks of causing sort of developmental abnormalities are lowest in that trimester. I have heard about high-risk pregnancies managed with hydroxyurea in the third trimester in this country. And I think all use of hydroxyurea in pregnant women requires a real informed consent conversation at this point. But given that we know pregnancy, I beg your pardon, we know that pregnancy is so dangerous for women with sickle cell disease, or can be so dangerous. I think that it's a really fair question to ask, and really just requires a really rigorous informed consent process, given what we don't know.
Okay, and one last question came in. Someone wanted to know, is there like a protocol or standard of care for pregnant women? Like, is it more common for them to give birth naturally or C-section?
Yeah, so there seems to be, it's not super well described, but there seems to be a modest increased risk for C-section in women with sickle cell disease. In terms of whether, it looks like the question also involves induction or letting them go to birth and give birth naturally. In the US, at least, there's a pretty big practice shift. We don't really let anyone go past dates. So we don't let anybody go past 40 weeks without induction at this point. It's totally possible to go all the way to 40 weeks with sickle cell disease, but because pregnancy can be so hard on women with sickle cell disease, we often see them give birth closer to 38 weeks. And sometimes that's done with induction, either because women are just having a hard time, or because they're having frank complications like eclampsia, preeclampsia. So again, I think that it's a really important question, and that there's not one right answer. It really depends on the person in front of you and what they're experiencing and what the concerns are.
Okay, well, this was great, everyone. Agnes just put the link in the chat because we're going to move over to our patient panel where we're going to continue this reproductive health discussion. So we'll see you there.
Thank you so much, Dr. Peck. I will see you on the other side. Thank you.
Soon.
See ya.
So